Okay, great. So my couple of case presentations that I have is essentially an extension of the talk that I gave this morning. So we're going to go through the cases, and then there'll be some educational slides after the cases. And then there's also a few spots where, as they call in EPIC, some hard stops where I'm not going to keep going until you answer. So be prepared for that. So the first case is a 54-year-old female with long-standing Crohn's disease. In the past, she's had a total proctocolectomy with an endoleostomy, and she presents with a new abdominal bulge. So she comes in, you can see she's got hypertension, diabetes, and a couple other surgical repairs in the past. She's a non-smoker, no other or real alcohol, no illicits. She does work as a stalker in a warehouse. Allergy to penicillin, and you can see her medications. So she tells you that she first noticed the bulge next to her stoma a couple weeks ago. She says it doesn't really cause her any pain, but she just doesn't like the way that it looks because it's kind of sticking out around there. She denies any nausea or vomiting or any recent changes to her ostomy output, quality or quantity. No blood in her output, but she does feel like for the past month that maybe she's having a few more appliance leaks than she has had in the past. On her physical exam, everything is relatively normal. She is overweight at 259 pounds. And then on her belly exam, her ostomy looks pink, patent, and productive. And then lateral to stoma, you do notice that there's a moderate-sized bulge that's approximately 5 centimeters in diameter, which is more pronounced when you have her Valsalva. You don't notice any skin discoloration or problems with that. So, what is your diagnosis, and what do you think should also be in your differential? So this patient had an asymptomatic peristomal hernia. The asymptomatic part's the important part when it comes to when we're going to talk about treatment. As far as what else could be in your differential, it's a little less likely, but there are a few things, especially because she is a Crohn's disease patient. So just because it's a bulge next to your stoma doesn't mean it's always going to be a hernia. So depending on what else they're telling you, they could have an abscess that's forming underneath there. They could have a fistula that's starting to burrow through. And then also something to think about is that sometimes with these loop stomas, we, like I said, we try to sometimes put the efferent loop a little lower, and sometimes they can kind of be beneath the surface, and so that can kind of mask a hernia, but like I said, I wouldn't worry about that. Another thing to keep in mind is that in these patients, we generally, unless we're concerned about some of these other things, based on other things that they're telling us, the diagnosis is a clinical diagnosis that can be made, so it rarely requires any imaging. So in your case, if you're seeing this patient in the clinic, you would just want to refer them to the colorectal surgeon, both just so they can get a formal assessment to confirm the diagnosis, even if you're pretty sure that's what they have, but also for education so that they can know, what they should look out for moving forward. So for this patient with the asymptomatic peristomal hernia, what would you plan to do for them? So the device is a great idea to help support. What else? Anything else you would recommend? Are you going to recommend to stop all lifting? Kind of, right? So you definitely want to tell them to avoid it if they can, but obviously, you're not necessarily going to tell her to quit her job if it's required. Sometimes we can recommend if they can get modifications. So sometimes if they realize that this is causing this problem, then they may be able to modify what they do with their job or get some, lighter duty options. So that's where the education comes into play. So there's just a couple other things. So obviously the biggest thing would be the hernia support belt. We also sometimes kind of recommend that patients use these from the get-go. So if they have a lifestyle, and if we would have, seen this patient before knowing that she was a stalker and lifting heavy things, you can use them for preventative measures as well to prevent them from even getting a hernia in the first place. It's obviously not foolproof. People can wear hernia support belts and still get hernias. We, all the time in the hospital, make makeshift ones where we just use the abdominal binder and we just cut a hole in it. Although I will say I've seen some where people cut a hole like this big, and I'm like, that's not really doing anything, but you want just enough of a hole to allow the output to come out without, being too compressed. Sometimes we will, if it's not very large, we can even trial changing their appliance and using a convex wafer. So again, just like if that stoma is retracted, that we can use a convex wafer to push that skin around. If it's just a small bulge, using the convex one will kind of push it down and create some support. Again, we talked about avoiding heavy lifting. The other thing is encouraging weight loss. This patient was overweight, and a lot of times if we can just get that big belly to go down a bit, then the hernia is going to be much less pronounced and less of a problem. And then again, one of the biggest things on here is education on the signs and symptoms of both strangulation and incarceration and when they should be worried and call us or go to the emergency room. So that's really important. And for your practical purposes, like I said before, I would also refer them to colorectal surgery and make sure they're getting a formal evaluation. And again, moving forward in this patient, the goal is to prevent progression of the hernia and the size of it increasing, because as of right now, she is asymptomatic. However, 9 months later, the patient presents again in your clinic just for her regular follow-up with you, and she says that the hernia is now significantly increased in size. She's now having pain whenever she's exercising or coughing. It's starting to affect her job. She's again has no change in her ostomy output, quality or quantity, no bleeding, but again, the pouching, which had been a little bit difficult, is now becoming a daily problem. She's leaking almost daily. She's very distressed by this. She's been working on losing weight like you recommended and is down 20 pounds, but recently also had to reduce her exercise secondary to pain from the hernia. As you can see, her weight is down. Again, her exam hasn't changed too much except for now. Again, the same hernia, you are able to kind of feel a fascial defect of about 10 centimeters. You are still able to retract it, so it's not, or to reduce it, so it's not incarcerated or restricted. And she has a little bit of pain when you palpate during Valsalva. So now what would your recommendations be? Yeah, absolutely. So in this circumstance, absolutely, you're gonna send them to colorectal surgery, and I would probably say also follow up with this patient and make sure that they go, because as we all know, not all patients that you just put the referral in and press sign order actually make it to the surgeon. So refer to colorectal surgery, and then again use that time in the office for education to review those emergent signs and symptoms for when they should seek out emergent care. So just a little bit of a review again. Any stoma that we create is an intentionally created hernia, so keep that in mind. But over time, they're gonna, that intra-abdominal pressure can cause tissue fatigue and enlarge that stoma opening and increase the likelihood. And again, remember that it's extra bowel that's coming up alongside where our opening is. Really big problem, affects up to 50% within the first year. And then again, these are all of our risk factors. Again, this is an example of what the support belts look like. Sometimes patients will come in and they think they're using a support belt because it's a skinny belt that just attaches to the stoma appliance itself. That's actually not a hernia support belt, that's just a support belt, so the weight of the output in the bag isn't causing it to pull down so that it comes away from their skin. So it has to be a thicker, more supportive belt to actually help with the hernia. And then again, like we talked about, you can modify the appliance and then modify their activities, and then surgical repair is an option when they start to cause a lot of problems. So for the second case, this is a 25-year-old man, male with ulcerative colitis. He's also had a colectomy with an endoleostomy, who presents with new peristomal skin lesion, and I believe this is an actual patient, and he was actually after his first step of a J-pouch. So the idea was that we were going to get him better and then move on with his other pouch procedures. So he actually was initially diagnosed with Crohn's disease, and then it was changed to UC a little bit later after he had some different biopsies that came back more consistent with UC. He doesn't smoke, which is good. He doesn't have any other illicits. He's a student, no family history, and his review of systems was normal except for his skin irritation. So this is per his, like I said, he was initially diagnosed with Crohn's disease. He'd been on some biologics. He had some adherence issues due to insurance and compliance. And then, like I said, was changed to UC. And for the most part, he's been compliant on his meds. He came to us. That was all done at an outside hospital. And then he came to us and required the emergent colectomy for a sigmoid perforation. And he also had a fistula and PE and all the other complications our patients can get. Again, at the point we were at this point is that we had asked him to lose weight before moving forward with the second stage so he would have a better outcome. And he had some complications with non-healing wounds and some nutrition visits. So when he presents to see you, he states he's overall been doing well, but for the past few weeks, he's got this new skin irritation that he hasn't had before. Causes him pain and frequent leaks, no change in anything with his ostomy, no bleeding, denies any obstructive or blockage symptoms. On physical exam, again, he's overweight, otherwise no other concerns. His stoma looks fine, but he does have some scattered areas, mainly on the right side, whereas the skin looks pretty red and irritated. And then he also has a few areas that have some linear excoriations, and the irritation is not exactly uniform. So for this patient, what is your diagnosis? And then what are some other things that you might be thinking, but what's your initial thought? Anyone? So he's got some skin irritation. His leaks have been more frequent. It's kind of always on the right side. It's not uniform. Right. So in this case, you think, well, it's probably not the adhesive to the back because you'd see it uniform around the whole skin. He's having more leaks, so whenever you have leaks, that caustic output sits on the skin. I know this patient well, so I know he's not very compliant, and every time I see him, his bag is leaking, and he's like, whatever. So I know that he probably sits for a long time and doesn't change it when he should. Yeah, and then anything else, so it could be leaking, could be, it could be an appliance. Maybe he's only putting, a skin barrier on one side or, things like that. But yeah, so initially, we're like, well, it's just some skin irritation from that's mechanical from his appliance leaking. But obviously in the back of your mind, we're going to try some things, but we should also be thinking if this doesn't work, is it a fungal infection? Because again, like I said, it's warm and moist. Is it an adhesive or an allergy to the adhesive? Or also those kind of specific skin diseases that also could come into play. So what would you recommend this patient to do? And this is, let's say, you don't have the WOCM that can come in and see the patient and you're just trying to give him some initial recommendations while he's in your clinic. So, ask him what he's doing, watch him do it. You want to make sure that the opening is not too big. Sometimes we have barrier rings, all those things. And again, I wouldn't expect you to know all these little details, but that's a good first thought of just how is he doing it, and then, we can make some initial recommendations on that. So, a lot of times when there's actual skin irritation, we use stoma powder and some what we call skin barrier wipes, where we call it a crusting technique. So we're basically applying powder and then a wet skin barrier wipe and then powder, and you're basically crusting up that skin so that when you are applying the appliance to it, and if something does leak on it, that skin is protected. Again, a lot of education about, a patient likely knows that it's going to leak or leak eventually because it'll start to get itchy and you can feel it under the skin, but it doesn't mean it's going to leak in the next 5-10 minutes. So some patients, push their luck and they'll wait hours or even, till the next day because they know they have some time. But that's when you get the skin irritation because it's all of that stool and output that's sitting on the skin. And it's the exact same thing as a really bad diaper rash. It's just a little bit harder to manage because you can't use all the same creams and whatnot that we can for a baby. And again, we could have him try a different brand or appliance. Maybe it's not that he's allergic to it, but maybe that brand just isn't sticking as well and something else will. And then we have a heavy-duty Marathon, it's called Marathon Skin Protectant that we use. It basically looks like super glue, and it will protect the skin for a few days, which can be super helpful. So the same patient 1 month later presents again for follow-up, and he says that he's done everything that you've recommended and been compliant, but the pain and irritation is worsening. Now he has severe areas that are increasing in size. The back's not sticking at all. He's miserable, but other than that, he doesn't have any other changes. And then when you look at his exam, this is what it looks like. So obviously it's much, much worse. You see these large weeping ulcers. It's got some violaceous borders. It's extremely tender, but otherwise the rest of his exam is fine. So anybody remember what that might be? Yeah. So this is an example of peristomal bioderma gangrenosum. Definitely, in my clinic, I've only ever seen it in IBD patients. I've never seen it in anyone else. And so when, of course, this often happens, when we ask the patient and we said that pyoderma and thinking that he's not ever going to know what this means, and try to explain it. He's like, oh yeah, I had that on my legs like 5 years ago. And we're like, oh, okay. So when he had it before, he actually just used a steroid cream and the lesions resolved. And he hadn't got it back since. But for this patient, what would your recommendations be? Besides the dermatologist, what else might you be thinking? And besides a WOCN to take care of the skin, what's the third component that you guys would actually be most involved in? Exactly. So for the GI component of it. So again, we want to refer to dermatology. Sometimes a biopsy of the area is needed for diagnosis. The one important thing for the topical and for the stoma patient is that we can't use all the same steroid treatments that we could use in the arms or legs or somewhere else. So the best thing that we have is actually a clobetasol foam, so that it'll dry really quickly. You're still getting the medicine to the area, but then you can pouch over it, and it shouldn't interfere too bad with adhesion. And then obviously we want to refer to GI to, probably needs a scope, probably needs to get the rest of the bowel assessed to find out if there's active disease elsewhere. The other thing for this patient is if this is going on and he's having this, we're in the process of doing a J pouch procedure. So what is this going to mean for him? Does he possibly have Crohn's? He's got all those kind of signs before of fistulas and things. That was all done before, our hospital. But so that would also be, something that we're not going to move forward with any other surgical procedures with him until we get all of this under control. And again, it also might require systemic therapy. Even if they do a scope and find that he really doesn't have that bad of a disease, if we can't get this under control, he still may require systemic therapy just for the PG or on the stoma. So again, just to quickly review the skin complications, the ileostomy patients generally have more complications, and usually that's because that output's a little bit more caustic, and it's a really big problem that often goes unrecognized. So that's where you can help out with your patients to find out, even just asking them. Oftentimes they'll be at the GI doctor and they don't really ever ask them about their stoma. But you also have to remember that a lot of these patients, if they're not having a lot of big problems, they're not following up with colorectal surgery on a regular basis. A lot of times, especially for the UC or the permanent stoma patients, we tell them to come back if they have a problem, but they're not seeing us on a regular basis all the time. And then just keep all these things in mind. Kind of have to think about those derm principles, that it could be a number of factors that might be involved. As I said, a lot of patients don't seek help, but the main thing for them to remember and for you to remember is the skin should look exactly the same as the rest of the patient's body. And then for PG specifically, it's a rare inflammatory skin disease. It doesn't happen very often, but definitely more common in IBD. Painful ulcers, that's probably the biggest difference too. Like if for other patients with just regular skin irritation, it can be painful, but if you're not leaking on that skin, and generally they don't complain about it too much once you pouch it again, but in these, they will be painful most of the time. And then again, you're looking for something that's gonna look asymmetrical with some violaceous borders, and this isn't hard to look at this and say there's something else going on here. And then obviously sometimes we need a biopsy as well. And then that multidisciplinary approach that we talked about.